Okay, so welcome to the fifth version of i2Eye 2022. We're really happy to have many of you here in Paris and even more of you online. I think the numbers will build up during the day, so we're really excited to have you here. First of all, I wanted to thank the organizing committee, who've been obviously very helpful in getting this going. So Michel Paques, Ethan Rossi in Pittsburgh, Pedro Mecê, Olivier Thouvenin, and Kyoko Gocho, who've all helped me out a lot in organizing this conference. I also wanted to thank, sorry. Okay, now I can change slide. I also wanted to thank our sponsors for this talk. So the Foresight Project, which has provided the money for the your lunch today and the coffee breaks, etc. Verschueren, who is the French clinical research network, who've helped with the administrative aspects, and then the Groupe de Recherche of the CNRS, IMABio, who have supported the invited speakers who have come here. So thanks very much to all of them. Also the institutions of each of the organizing committee I wanted to thank. And then two people that I don't want to pass over. They've been sort of invisible on the organizing committee, but have been of enormous help in getting this conference going. Nate Norberg, who's engineer in my team, who's not here today, but has been massively helpful in getting all of your inscriptions, etc. online working. And then Carole Romand, who's helped with all of the administrative aspects. So just to introduce our research group, I think a lot of you know it, but the idea is really that we're in a hospital setting and we're developing new optical imaging tools. So we're working with the clinicians on a day-to-day basis, but we're a group of engineers and clinicians who work on new optical setups. And if those are showing some interest on imaging of patients, then we'll move towards a prototype or even a commercialization. And so we've developed either with custom systems or in partnership with different industrial partners, a number of different technologies over the years, mainly based on OCT, adaptive optics, and holography. And you'll see some of those if you come and visit our facility tomorrow. But in developing these different systems, we noticed that there was a real need for dialogue between the clinicians and the engineers. If each develops, if the engineers develop the tools on their own, then they don't know what the need is. And if a clinician uses a tool that he's not familiar with, then they can't get the best out of it. So we created this i2Eye conference. The first one was in 2018, really to get this dialogue going between clinicians and engineers. And the first one was just based on adaptive optics. It was really focused on the clinical device from i2Eye. And it was quite a, sorry, there's some sound on top of that. And so the conference in Paris in 2018. In 2019, we had success in the first meeting, and then we added OCT for the second time. We had some invited speakers further afield. Sorry, I'm hearing sound. Followed by 2020, when of course during COVID we had to move online, but that meant that we could have many invited speakers because they didn't cost us anything. And so we had a really interesting meeting with many participants. Last year we were hoping that it would be live in Pittsburgh, but again COVID restrained us to being on Zoom instead. But again we had a successful meeting with really good interaction, over 100 participants. And so this one, here we are, we're in a hybrid format where we've got some people online, some people here. So we hope that the organization permits both people to interact. We've got a 3-day multidisciplinary conference. We've got a mixture of clinicians, imaging experts, biologists, and computer scientists attending. We've got around 50 international speakers and poster presenters. Around 60 of you are going to be in Paris, and around 100 more have signed up to be online. I want to thank the invited keynote speakers who've given their time. So Rigmor Barras from Norway, Olivier Gouraud from here in Paris, Rainer Leitgeb, who will join us remotely from Vienna, and Jessica Morgan from the US. And just to give a little preview, although we'll finish up with this on the final day, next year we'll be moving to Pittsburgh. The idea is to have 1 year US, 1 year Europe. So that will be the rhythm. So next year Pittsburgh, and then 2024 back to Europe. Just for the basic rhythm of the conference, so today we're beginning with some introductory courses in biology, optics, and ophthalmology. So this is like the for dummies type of courses where you can really get some starting information on the different disciplines. We're going to follow that with a poster session and our lunch, and then we have 2 sessions in the afternoon of submitted talks and invited talks, firstly on novel technologies, and the second on histology, organized, and disease models. Day 2, we have visits in the morning, which I'll explain in the next slide, and then 2 sessions on functional imaging and eye movements, and then anterior segment glaucoma, followed by a clinical case share. So this will be animated by Michel Paques, and it's really an opportunity for clinicians who may have some interesting data that they don't necessarily know how to interpret, or a really interesting case that they've seen that they want to share, to really just come up and present a couple of slides and discuss. So feel free to contribute, even if you haven't told us in advance. Just feel free to come up with your clinical case if you have one. Day 3, we'll have a second opportunity to visit. And then we'll finish up with 2 sessions, retinal cellular biomarkers and blood flow and vasculature. Okay, so just a few requests. So first of all, if you have a poster, please put it outside so that it's available for people to walk around and talk to you during the break. You can also send it to me in PDF after the conference if you want it to be added to the online content, because these talks will be recorded and put online following the conference. If you're giving a talk, can you come with a USB stick and put the talk onto the communal computer, just so that we can transition easily from one talk to the other. The talks will be available on Zoom after. If you don't want your talk to be recorded and put online, then let us know and we can exclude it from what goes onto the online part. There is a Zoom link. If if you can't attend every session in person, even for those here, you can join on the Zoom link. It's also on the website. And then just a point about these sign-up sheets for the visits. So to visit the labs, it's a fairly small space. There are patients, etc. So we want to divide you into groups of about 10 people. And so, I'll come back to that afterwards. And so you'll see that outside the room here, there's a sign-up sheet where there's different slots for either a clinical or a technical visit. So there's no need to sign up for both. It's just more of a clinical focus or a technical focus. If you're, one of the visits will be telling you about which wavelength laser is, and the other one will be telling you about an interesting patient we saw, but it's otherwise the same technology. Just one point, if some people might need attendance certificates for proof for their administration when they go home, they can contact this name at FCRA. You can ask me after if you need that contact. So just for the sign-up sheets, they are outside. So for example, if you can put down your name here, I've put my own name. If you can include maybe your email address in case we need to contact you to let you know anything about the visit. Please don't put yourself in 2 columns, as I said before. And then also, if a column is full, please don't add your name at the bottom. We'll come back and add more visit occasions. Because we really want to limit it to around 10 people so that everyone can really see what's going on. For those who are online, if you can mute your microphone and turn off your camera during the talks and then address your questions in the chat, that will allow the moderator to address those questions afterwards. On the other hand, during the discussion periods at the end of each session, please feel free to really join in by unmuting and turning on your camera and joining in the discussion. That would be really nice to hear from you if you're online. And again, all the presentations will appear on our website later. Just a quick slide to say that anyone interested, our group are actually hiring for a couple of different roles, for a lab manager role, a couple of research assistant type ingénieur d'études roles, and there's sort of continually research opportunities to participate either as a, postdocs, doctoral students, internships, and even as a study participant if you want to volunteer. So please don't hesitate to ask us if you're interested or if you know anybody who would be interested in working with us here in Paris. Okay, so I'm going to pass on to the first session, and I'm going to welcome Michel Paques to talk about the eye.
Thank you very much, Kate. And you've been too modest because you've been really instrumental in preparing this meeting. And I'm always amazed by your talent for organizing such complex things. And thank you again for all the work you've been doing. I learned a lot about how setting up a meeting just by working with her. So, where's my page? Screen share. I don't promise. Okay, does everybody has the image full screen? Daniela, is it okay? Can you answer me in the chat? I don't see the chat. It's supposed to be okay. C'est bon pour toi? Okay. So, as Kate said, it's a basic course for dummies. So I will be the dummy for the next session, for instance. So it's not, this particular topic is, of course, not for ophthalmologists. It's more for those who will be interested in ophthalmology, who barely have an idea what's an eye, what's the fundus of an eye. And of course, in half an hour, spending through the ophthalmology it's quite a challenge. But I focused on specific disease and specific techniques, essentially, of course, fundus imaging and age-related macular degeneration and diabetic retinopathy, which are, let's say, the most common cause of retinal disease we see in the clinics. So I'm an ophthalmologist by training. So I'll tell you a bit about my experience with patients and imaging and the relationship between disease imaging and a little bit of the future, and introduce the other talks of the meeting. But because of course the idea is to show that the current state of the art, the limits, and what we expect from future progress as doctors for helping our patients. So first of all, everybody in this room and probably most of in the world have seen a fundus image, even if you don't really identify this as a fundus image. It's just the red eye phenomenon that you see when you photograph. Ah. Je vais refaire le partage. Oui, je sais, il faut mettre l'écran. Je partage ensuite. Il faut que tu arrêtes. Je partage le plein écran. Je partage tout l'écran. C'est là, c'est là. Ouais, c'est là. So everybody seen this red eye phenomenon. It's linked to the fact that the incident and reflected light go through the same axis and are captured by the camera. So that's because the fundus is a mirror. A few significant number of photons that you send to the fundus come back and it can be captured. And so the red eye is the redness of this, the red eye phenomenon is the correlated distance of the pigment and the fundus. So this is the principle of fundus photography. Based on that, you coaxial illumination and observation. And a variety of systems are available. Historically, the first one was from fundus camera that was invented 100 years ago. And this is a pathway of the light that you can see going through the cornea, the lens, and capturing the photons emitted from the area of most interest, which is the posterior pole and the choroid, and especially the retina. So the retina is a flat layer of neuronal cells. Located at the fundus, the eye can be considered more or less spherical, if it's not totally true. And but now it's been sorry. So and currently there are wide field camera that are available, such as this one, for instance. So we have a very nice view of the fundus. What we can already note is that the the pathway of vessel is very specific for one subject to another. It's kind of a fingerprint of the fundus. So let's say it's specific to each patient. You can identify a patient just by the pattern of vessel in one eye. So the area, as we clinicians are more interested in the center, the macula and the optic nerve. And this is where all disease affecting vision and everyday life concentrate. Disease affecting the periphery have less immediate effect on everyday life. And this is why the high resolution imaging may be really important, because it's concentrate on the microscopic analysis of this very small zone, which measure at the center of the center of the macula, the fovea, measuring approximately 300 or 400 micron wide. And this very small area had a disproportionate importance in everyday life. For if you read your cell phone, it's because of the fovea. So that's why we need high resolution systems, because with the conventional fundus photograph, we have very little details of what actually happens in the fovea. So this is an illustration of the variety of fundus aspect that you can see in the everyday clinic. The name of the disease and the different fundus aspects, and for a given disease, you may have a vastly different aspect as well. So it's a matter of training. It's a long period of training. You recognize rapidly the pattern that may give the diagnosis. Often with little experience, fundus imaging may be enough to give an idea of the diagnosis. But the revolution brought by optical coherence tomography really brought us to another level of precision. So fundus imaging gives you an all-fast image, but thanks to OCT, you have a transverse image. And we have access for the first time to the retina itself, because if you look at the fundus, such as here, you only see the coloration of, you don't see vessels, you see the coloration of the pigment epithelium, which is a layer behind the retina, but you don't see the retina itself. To see the retina, you have to use optical coherence tomography and to see this. So the retina is here. This is a choroid, which is give the orange illuminated light coloration of the fundus. And thanks to OCT, now we have access to the retina and the different layers of the retina, which correspond to the specific neuronal population, which is the nice thing in the organization of the retina. That each layer corresponds to, let's say, few cells types, which are already sorted out just by the location into the retina. And the layer, what we're interested in is here, the photoreceptor. So light goes from there to there, the anterior segment is here. And you have interaction of light with photoreceptors here, and the signal is processed and goes back to the optic nerve here. OCT brought to us the possibility to make even finer diagnosis. And this is an illustration of what you can see. This is a normal retina with a foveal depression here. And this is an abnormality, which is related to age-related macular degeneration. It's a proliferation of small vessel coming from the choroid. And this age-related macular degeneration really boosted the sales of OCT, and correspondingly there are an increased number of companies interested in selling OCT machines, because we now have a treatment for that, and OCT is now the hallmark, let's say the most importantly used diagnostic tool in ophthalmology, and probably even in the world. I think it's the most frequently performed medical exam done in the world. There's a $1 billion market annually of OCT machine. And another progress was brought using OCT by the extraction of the pattern of vessel. You can, by doing differential imaging between two OCT scans, you can extract the information of blood flow. And this gives rise to these nice maps, which outdated another exam, which is fluorescein angiography, which I will not really talk much about today, because it's more part of the past than of the future. So now we have non-invasive imaging, not only of neural structures in the retina, but also of vessels, and to the smallest vessel, to the capillaries. In the imaging, you can combine also wavelengths, red, blue, green, and all corresponding to different, you can excite different fluorophore by fluorescence. So now we have really a wide array of imaging approaches that you can use to have even a final diagnosis for patients. So there's an opportunity to develop these different technology. There's also some development concerning multispectral imaging, but this will be discussed further during the meeting. So I'll concentrate my description of retinal disease on two diseases, one affecting the vessel, this is the fovea of the vessel on the inner surface of the retina, and some vessel in the cornea here, and I'll describe a little bit disease affecting the vessels here, the diabetes, and the disease affecting what we call the outer retina, which is age-related macular degeneration. So age-related macular degeneration, or AMD, is a very common disease, of course, linearly linked to age, but also to genetic factors. And it starts insidiously with the appearance of these yellowish spots that we call drusen, which are totally asymptomatic and normally detected by fundus examination, such as in this case here. And OCT is also very precious to diagnose these abnormalities here that may be more or less high, more or less numerous, which are not actually deteriorating the retina, but they may prepare they may be complicated. We know it's a necessary step for future sight-threatening complications, such as what we call late AMD. This is another illustration of drusen. This is histology. So we are here in the retina. The retinal thickness is overall here, and this is the retinal pigment epithelium, the photoreceptors. Drusens are here. Different type of drusen can be diagnosed, and OCT also is very helpful to diagnose that. So we have a quite good knowledge of what happens at the early stage of AMD thanks to OCT. And this is an illustration of a navigation image, a large image of adaptive optics montage image showing a patient with drusens. So it's a very complex change that can be observed when you go higher in resolution. This raises the issue that we'll talk about. It's a correspondence between the histological changes and what we can now see using high resolution system. We have much more information brought by these systems. So we will gain more fundamental knowledge thanks to the association between histology and high resolution imaging. So that's what the early stages of age-related macular degeneration, and what happens at the late stage, the patient may lose vision. There's two pathways for losing vision. One we call the dry form, and the other the wet form. Dry form is this appearance of these plaques, which are in fact the absence of a specific layer, which is a retinal pigment epithelium. Starting by a little one and increases over time. And this is different, although it may be associated to this form. It's a proliferation of a vessel from the deeper layers, which may bleed into the retina. You see these hemorrhages here. And both are, of course, very deleterious for vision, but only one can be treated. Only one can be treated in the wet form. So starting with the dry form, which is focus of most of my clinical research. This is a small area of atrophy here, a much larger here. So it's unfortunately really common. There's no treatment. This is OCT image of one of these cases. There's a very complex change that can be identified by OCT. The interest of OCT is also to detect the transparency of the retina. And you see here the retinal pigment epithelium is still present. There's kind of a shadowing here on the deeper layers, but when the pigment is lost, when the RPE is lost, then you have transmission of light. So this, looking at the transmission of light through the eye, gives information. And this is supposed to be an animation here. Unfortunately, it does not work. So there was a video showing the progression over years of this plaque of atrophy, which started at a small white spot and expands. So sorry, it doesn't show up on this presentation. Let's keep this one. So So we know that what happens in dry AMD is very complex on the histological side. This is a close-up of the retinal pigment epithelium. You have here the photoreceptors, and you have duplication of RPE cells, change in their disposition, disappearance, or local proliferation. So it's a very complex issue that still needs to be fully deciphered, and we hope that high-resolution imaging may help us to understand what's actually going on. Imaging. This animation works. Okay, this is another illustration, and this one, that's what I wanted to show you. And unfortunately, it's not going. You see patient, the progression of atrophy over years, and the corresponding OCT shows also the progression of this atrophy toward the periphery, and of course, the larger the lesion, the lower the vision. And this is an example of wet AMD when there's proliferation of vessels going from this layer under the retina. This proliferation can be identified by OCT angiography as well. You see these arborescence of vessels, which are deleterious for the retina because they destroy the structure of the retina. And this is visual loss is often very severe. Fortunately, we have some treatment now. This is schemes of what actually happens. Fortunately, we do have a treatment for the wet form, which is intravitreal injections. This is a scheme showing what actually is done. It's under local anesthesia, and we know there's a zone in the retina, in the eye, which we can penetrate with a small needle and give them molecules that will block the process of proliferation. And this is what has been a revolution in care. It's currently the most prescribed treatment in France. It's a $1 billion yearly with the expenses from Social Security, but it works because it's really efficient. We can control the proliferation with the drug for many years, and it's been thanks to that decrease in the number of blind people in Western countries. But of course, it's very expensive. I'll show you a few images of another very frequent disease, diabetic retinopathy. So diabetes can affect many organs. But the eye is really useful because it's a biomarker of what actually happens in the rest of the organism. And you may have infraclinical lesions, such as, for instance, these spots here, which can be either small hemorrhages or microaneurysm. At that stage, the patient sees perfectly well, but that's an indication that diabetes is actually damaging vessels. And this is a target of diabetes is small vessels. You see here, on this image, the diabetes gives rise to these small lesions here, schematized here. And this is histology of the same, of the microaneurysm. We don't exactly know the cause of these lesions, and they may be dispersed all over the fundus. And if they're very numerous, they locally can induce some edema in the retina, and plasma components such as lipids. These white spots, these yellow spots here are lipids from the plasma going through capillaries and invading the retina, giving rise to this deposition and thickening also of the retina. And on the OCT, you can have this enormous cysts in the retina due to edema. But the nice thing is that the retina is very resilient. Despite such a thickening, it may recover under treatment. And that's always fascinating for me, the tolerance of the retina to many trauma, such as extensive edema. And it's always surprising for me to see how this retina can heal. And again, the treatment is the same as for wet AMD. It's the same drug that we use the same way. So this treatment is very polyvalent. We use it for many retinal diseases, and it made us retinal specialists to become really not only surgeon, but also actually curing diseases. Other treatment have been developed for diabetic retinopathy. I'll say a few words about laser, because by studying cases of diabetic retinopathy, we identified that there may be targets, specific zones in which it's interesting to put a laser burn to destroy the source of the edema, because the edema does not come from every vessel, it comes from few vessels. And we may identify these vessels with a specific technique, ICG. I won't talk much about it, but laser therapy may be applied to these lesions, and we can also obtain nice reduction of edema using this. But the diabetes, as for AMD, you have two sides of the disease, dry and wet. You have also two sides of the disease in diabetes. I talked about edema, which can be cured, but there's another facet that cannot be cured. It's what we call non-perfusion. All these black zones here are due to capillaries that are not transmitting the flow anymore. So this is all black because it's, the white is when there's a blood going through. And when it's black, it's because it's dead tissue, dead vessels, and hence dead tissue. This is OCTA of a similar case. You see nice perfusion here and complete loss of perfusion. And even here it starts new vessels, and similarly as to AMD is also new vessels pop out and may be dangerous for the retina. And may grow to this and may even give rise to traction of the retina, and we may even have to do surgery to cure these cases. And again, also it's anti-VEGF treatment that may be efficient in some cases, but more often it's surgery, and also laser can be used not only for macular edema, but also for the rest of the periphery. And I'll end up my talk by talking about a little bit more of what can be observed in the eye beyond ophthalmology, because the eye can be considered in a way as a small brain. But many of the structures of the eye are seen in the brain, not only the general organization, but also at the microscopic scale. Some cells do the link between the two organs, such as ganglion cells and also vessels. And so the eye is the biomarker of general disease, especially of the brain. And we can observe in the eye manifestation of other disease, high blood pressure, for instance, Alzheimer's disease, multiple sclerosis. And so I believe the future of retinal imaging is also to look at neurological disease or high blood pressure. I think so. We always should keep in mind that retinal imaging may also have interest in general medicine. So now we have very powerful instruments. It competes in the resolution with microscopy. It allows really advanced exploration of basic physiological phenomena, not only for medicine, but also for science. And it's, sorry, I wanted to finish with that slide. So the future retinal imaging is, many options are possible. I cite a few of them: optoretinography, computational imaging, personal medicine, because we have very high precision measures, for instance, of vessels. I show you cases of showing interest in AMD. And also it's useful as for guiding therapeutics. So it's you will hear about that meeting today. Always keep in mind that we may have very good lab instruments, but the complexity and cost increase with the technicity, and we as doctor need also something that's robust and usually more precise, less robust. But that's a debate we always have in our team about what's really useful for the patient and what's is reasonable to do as imaging procedure. So I'll finish on that slide showing that the current state of treatment of many retinal diseases. We do a lot of intravitreal injection in wet disease. Some disease, unfortunately, are not available. Some treatment are not available for some disease, and now we're trying to reduce the number of patients in that line to increase the number in that line. Thank you for your attention.
Are there any questions for Michel? We have a minute or two for question, or online if there's any questions. Okay, if not, Michel will be around. You have a question for us?
Question about the edema always arising from single vascular or microaneurysm, or can you also have a generalized edema?
I think it's the number of sites that leak may accumulate and build up macular edema. And it's also the distribution, probably. If there's a lot of sites, a few sites, but close one to the other, then it increases the likeliness of having local increase in edema. If it's dispersed area in the periphery, there will be no focal accumulation. So I think there's also a lot of, let's say, mechanical factor to consider to understand what actually happens in a specific case. But in many cases, it's only one site. And this is why identification of these specific sites is very helpful for the patient, because sometimes just by giving one spot of laser, you cure the problem, but it's not always the case. Okay.
Great. So we'll move on to the next talk. It's Pedro Mecê. And just to tell you that if anyone wants a coffee or a pastry, there's everything available in the room at the side, so feel free to.
Okay. So I'm Pedro Mecê. I hope everyone in Zoom are listening well. If not, you can just send a chat and we'll figure out, but I think you all see my slides in full screen, I hope. Also try to share a virtual laser spot so everyone can see where I am in the slides. So I was invited to give a talk more for non-physicists about the basics of optical imaging in the retina, so about ophthalmoscopy. And I hope it'll be very useful, not only for physicists, but also for discussion among physicists. Okay, Michel already gave a very good talk about the clinical applications that we can have using different technologies. We're going to have soon a talk about Anna about the histology and the organization of the retina. I'm more going to focus on how light can be used to image the back of our eyes, the retina. So when we talk about optical imaging, we talk about image with light. Light, we can say that light is non-invasive because we are constantly being exposure to light during the day, and our eye is the main organ that's being exposed and converting light into neural signal. And so also using light wave as a promise of achieving, as in microscopy, cellular resolution. So I mean to have access to a deep neurovascular network, okay? So having access to supporting cells, to neurons, and blood vasculature. So this, for me, as a physicist and engineering, it's quite exciting and a good opportunity to move into development of instruments to have this type of information. So the eye itself is an optical instrument, okay? So in order to image the retina, we need to go through the cornea, the lens, to focus light into the retina. We have the pupil, the iris, that you change the aperture of our system. So the eye itself is an optical instrument. So how good is the eye as an optical instrument? If we ask Hermann von Helmholtz, he would say very bad one. So indeed, Helmholtz said, if someone would offer me an optical instrument with all these deficiencies, I would outright reject it. So Helmholtz said that in 1881. So Helmholtz actually was the first one that introduced the ophthalmoscope. So the first ophthalmoscope was created in 1851. This is what it looks like, the first ophthalmoscope. And the curious fact is that the introduction of ophthalmoscopy, fundus photography, was just after the introduction of photography itself. So photography was only 12 years before. So I thought it was very curious about how engineering and physicists already thought that we can take pictures from outside of the world, but why not using the same technique to take pictures inside of our body and our retina. So this is what looks like the view. So of course, here we don't have a camera at the time, but this is a draw from what people at the time, so in 1853, saw in the back of our retina. And if we look at the fundus camera, it's not very bad, actually. So here we are talking about more than 100 years after this first ophthalmoscope and the fundus camera of this image. So they have very good, can say, details and information about the retina already. But in the past, I would say 30 years, we have a real revolution. Here I listed very few of them, just to give an idea. So from the first ophthalmoscope, we can also highlight the invention of confocal scan laser ophthalmoscope, OCT, as Michel already mentioned. We can talk about adaptive optics ophthalmoscopy. And I choose one recent application, which I think would be also one of the keys for the future. It's optoretinography with functional imaging of the retina. Okay, so this is all to give more or less a motivation, and we're going to see some of these images during the talk. The outline of my talk is first to go step back and talk more about the requirements and basic concepts of optical retinal imaging, and then introduce the challenge in retinal imaging and how can you address them. So I'm talking about aberrations, eye motion, photometry, and scattering. And then we're going to very quickly, because I don't have too much time, to introduce methods to generate new contrast in the retinal imaging. But fortunately, most of the talks today and tomorrow and the day after, we will introduce deeply these new contrasts in order to have different information from the retina. So let's start from the beginning. And when you are talking about optical imaging, we have basically two main configurations. So we have transmission, where you have a light source, which goes from a medium and an optical system, goes to the object, light is going to interact with the object, and some light is going to be transmitted, go to a medium and optical relays, and can be detected. But in the case of the retina, the most common way to image the retina is by reflection. So this schematic is the following. We have a light source. We're going to pass from a medium and optical instrument, goes to the object that we reflect or backscattered light, which goes to the medium again at the optics and is detected by photodetector or monodetector. Okay, so the goal in optical imaging is, and where I'm going to focus, is to map basically the reflectance of the object, the reflectance of the retina, and I'm more going to focus in using the intensity of light that's being detected to generate this image. I could use also the phase, but here I'm going to focus more in intensity. So what are the imaging requirements in order to have best image that we would dream in the retina? So the first one is thing to have in mind is the spatial resolution. Okay, so the retina, it's composed of tightly packed neurons whose major components, somas and axons, organized loosely into stacked layers. Okay? So they are often forming mosaic, regular mosaic, as you can see, rods and cones here. From histology view, but it can go from this very small, so hundreds of nanometers, to the very big. As you can see in the fundus, we have the optic disc that can have size of 2 millimeters, some arteries and veins. So this is a picture that we could spend a lot of time looking at about different sizes in the retina. But it's not only a question of having the good resolution to image the size of these features. As they are tightly packed, we need to separate them. So we need to have enough resolution to separate adjacent cells. So what will help us, it's diffraction limits. This is our goal. The optimal spatial resolution that we want to achieve is limited by diffraction. I think my colleague Olivier will talk more about that later. But here it's what we have as a formula. I promise that I'm not going to show too much from us. But this is a very important one. So the lateral resolution is given by the wavelength, so the color of light that we are using to illuminate, and the numerical aperture is the angle of collection for detection of photons. So we can also translate that into this very simple schematic where you have an aperture with a given diameter and a focal length. And this will give our lateral and also your axial resolution. So you come to that later in the case of the retina. The second requirement is sensitivity. So what's the weakest reflectance to be detected? So actually this is quite challenging because most retinal cells are transparent to maximize light throughput to photoreceptors, which are lying just underneath. So this results in very small little light being backscattered from these cells, making them very difficult to image. So here you can have an idea what are the brightest one, like ISOS and COS, which are photoreceptors, and the RP and the nerve fiber layer, and the weakest one, such as the outer nuclear layer. So the brightest one actually is not that bright. Photoreceptors, you have to send 1 million photos, from 1 million photos sent to one photoreceptors, just one will be backscattered. So it's real challenging actually to image them. And when we talk about sensitivity, I have also to introduce the notion of signal to noise ratio. So the optimal signal to noise ratio, what you want is that to be limited by photon noise or shot noise. And just to give you a very intuitive idea what is this type of noise. So imagine that you have 4 buckets and it's raining. What would be the reality between these 2 cases? This one where you have an even distribution of droplets inside the bucket for a given time, or this one with more random. So the photon being detected by pixels, so pixels being the buckets, the droplets being the photons, it's more or less this case here, as you can think is the reality for also a rainy day. So if you were in this case, it would be the dream because you don't have any noise. All buckets, if they are evenly distributed droplets, you collect the same amount of droplets. But the reality is that you're going to have a variation. So you have an average signal, but you're going to have a variation between buckets. So this is a photon noise. There is a random distribution of photons that are not equally affecting all the pixels. And this will generate a noise, which is the square root of the number of photons. And we can define the signal to noise ratio as being the square root of the number of photons. And as we increase this, you can see here for this given sample, it's not the retina, that we can have better details and start to see, even if you have enough resolution, we start to see the details thanks to the fact that we beat noise in terms of signal. And we can say that with a good sensor, we keep this number in mind, 100 photons per pixel per frame, it's quite fine. A third aspect to keep in mind is temporal bandwidth. So what's the fastest dynamic process that we can detect? So vision involves millions of cells in the retina and an abnormality of biological process that occurs vastly in different time scales, from microseconds or less than microseconds as blood flow going through arteries or sparks from neurons. And we can also think about motility inside cells of organelles and also months and years as the follow-up of diseases in the fundus. So if you want to probe all this, we need a very fast acquisition rate. And of course, I'm more an engineer and physicist. My ultimate goal is to have everything. So have high spatial resolution, high sensitivity, and high temporal bandwidth. And of course, that in reality is not the case, because if you try to aim to have a very high temporal bandwidth, we're going to collect less photons, so we're going to have problems with sensitivity. We can imagine that we can optically change the pixels of our camera, for example, in order to collect more photons, but we're going to lose resolution, or we can just forget and give up about temporal bandwidth in order to have high sensitivity spatial resolution. So there's every time trade-offs. And as Michel said, there's also clinical needs. So sometimes we don't want to have the 3 of them because it becomes more costly, complex, and not robust. So we also have to keep in mind these basics that clinicians also need something robust, large field of view, and low complexity for clinical application. And things get even harder because we have some challenges that now I'm going to address. Okay, let's talk about the challenge. I'm going to come back to the 3D resolution in the retina. So you remember this formula. So we have a dependence as a function of the wavelength. So first, which wavelengths should we choose? To have the best resolution, we would choose short wavelengths, so go to ultraviolet, but can be dangerous for the retina to be exposure. We can think about visible light, but it's quite uncomfortable for patients. So typically, most of systems, they are going to near infrared, where it's quite comfortable for the patient, safe, and the resolution achieved with these wavelengths, it's quite okay in terms of cellular resolution. You're going to see there. We come back to the question of Helmholtz, how good is the eye? And we'll see that now. We see that theoretically, with this dependence, if we increase the size of the diameter of the pupils, we can use drops to dilate the pupil, we can achieve higher resolution. So for a 7mm pupil, we can theoretically achieve 2 micrometers. But the reality is that our eye has ocular aberrations for the cornea, crystalline lens, tear film. So there's dynamic aberrations changing over time. And you can see that the larger is the pupil, more aberrations will affect our final resolution, blurring the image, so we lose the details. So most of the systems in the beginning were limiting the aperture to around 2 millimeters in order to not be too much affected by aberrations, as you can see here. So I'm talking about confocal scanning laser ophthalmoscope, but you can see that we can have up to 7 millimeter lateral resolution, but the axial resolution is quite poor. It's more than the thickness of the retina. So we have more a 2D image of the retina with no axial detail. And that's why OCT was a revolution, because OCT technology gave access to a tissue resolution, because the axial resolution is no longer coupled to the diameter of the pupil, but it's completely decoupled and depends only on the light source properties. So as broader is the light, the spectrum of your light source, the better will be your axial resolution. So you can think about the axial resolution for 4 micrometers. But still, we don't see any cellular detail. And this was until 1997, when adaptive optics, which is a technology used in the beginning in astronomy, was first applied for ophthalmoscopy. So we could go from these cases to this case by using a good adaptive optics, so achieve this 2 micrometer resolution. So it's very fast how adaptive optics works. What is adaptive optics? The main principal things is that we are imaging the back of our eye, a light spot, a point source, which is backscattered by the retina and being detected by wavefront sensor, which will measure the aberration and pilots the thermal mirror in real time in order to compensate for this aberration. So when we are imaging the back of our eye and we are looking at the detector, we can see the effects after corrected aberrations. We can start to see the photoreceptors mosaic. So we can apply adaptive optics to any ophthalmoscope, talking about fundus camera, adaptive optics, and confocal scanning laser ophthalmoscope. Here is picture of the 3D resolution that we can have, but still you can see that the axial resolution is quite poor compared to what OCT can have. But of course, we can also add adaptive optics to OCT to achieve the highest 3D resolution and have the highest details, 3D detail of the retina. Adaptive optics still face some challenge in clinical deployment. We can decrease the pupil in order to decrease some of these challenges. But if you want to have the highest performance, you face some problems such as small field of view and high hardware complexity. So the small field of view is because of anisoplanetism. So you can have a very good correction for a given point in the field, but as you go away from this point, you see that the image starts to blur, because you have some field aberrations. So the correction that you apply for a given point is no longer good for a point in the edge of your image. So this patch where resolution is acceptable, we call the isoplanetic patch, and it's not bigger than 2 degrees. So quite small compared to the ophthalmoscopes that clinicians are used. Another problem is the complexity. So there's some techniques that try to move the complexity from hardware to software. So we're talking about sensorless adaptive optics, where you don't have the wavefront sensor anymore, but you are based on your image that you acquire and try to see some metrics that correlates with the correction of aberrations to pilot to the thermal mirror, or you can use a completely computational correction in systems such as OCT, where you can extract the phase, so measure the wavefront and correct for it as well. Or one of things that in Paris we try to work is try to make a system that's more robust to ocular aberrations. And there'll be a poster from Maxime talking about time domain full field OCT, which allow us to have high resolution without adaptive optics. And so we increase the field of view, so we can have 5 degrees by 5 degrees field of view. So we have the tools to have high resolution, so cellular resolution, but be careful with motion blur, because the eye is constantly moving during imaging. We're talking about involuntary lateral fixation eye movements and also axial eye motion. So there'll be some talks talking about them, but motion can also blur your image, so you lose details from the resolution. We have to have exposure time that's quite short. So talking about up to 5 milliseconds would be okay for this type of movements. Okay, let's do it. We have adaptive optics, short exposure time. Can we do a fundus camera adaptive optics image of photoreceptors mosaic? This is what we get. So I don't know, for you, it's a bit disappointing because it's very low contrast. Cannot say that we are seeing very clear photoreceptors there. And this is because of some extra challenge about photometry, scattering, and signal-to-noise ratio. So let's go through them. So remember this formula about the signal-to-noise ratio, and we conclude that 100 photons per pixel per frame, it would be quite fine. Can we achieve that in reality? If we look at the laser safety standards, so in Europe we use the ISO, we can send up to 5 milliwatts to the eye. 5 milliwatts for 1000 by 1000 pixels, it's equivalent to having 20 million photons per pixel per millisecond. Consider the reflectance of the photoreceptors being 0.001%. 7 millisecond exposure, a bit of calculation, we would have exactly 100 photons being reflected by photoreceptors. So this should be sufficient. So here the problem is not eye safety, could be, but this is not the problem. So what's the problem? The problem is that the retina, it's a 3D, very complex medium, so it's a scattering medium, and we are not only collecting signal coming from photoreceptors. So if we are aiming to image the photoreceptors, we put our optical system to focus in the layer of photoreceptors. This is what we want to image, but we collect more than the signal coming from this area. So there's some light that's not detected that we are sending in the retina, whether absorbed or scattered out of the pupil or being transmitted. We have some light singly backscattered by our in-focus layer. That's what we want to detect. We have some light being singly backscattered by autofocal layers and bringing blurred to the image. And some multiply scatter light, which also creates a diffuse haze that will also be detected. So this is our signal that are being detected by the camera. So it's not only S. And this explains why we have this. So if we plot profile of this figure, we see this very low spatial frequency, smooth signal, and some very high spatial frequency that might be photoreceptors. So this is the contribution of 2 and 3. And we can think that with imaging processing, we can get rid of them. And if I do that, this is what I have. So it's still very, very noisy. Because if we look at the signal-to-noise ratio, in the beginning, the optimal that I point to you is the square root of S. But as we detect all the signals, the reality, it's a bit different. And actually, the noise, all the signal that is detected contribute to noise. So at the end, our signal-to-noise ratio, it's much smaller than what we would have as optimal. For example, if we would consider the contribution of multiple scattering, which the majority of the photons that are detected have been multiply scattered. If we say that's 400 times the signal, we would have a signal-to-noise ratio of 0.5. So the solution that we can have is to acquire 400 images, align them, and average them in order to have the good signal-to-noise ratio of 10. But can we think about other way to do that optically? So we can change the geometry of illumination detection. And I'm talking here about spatial filtering. And this can be done, for example, with a confocal scan laser ophthalmoscope, where you're introducing a pinhole in illumination and conjugated to a pinhole in detection. That's why it's called confocal. They are the same focal plane. And with that, only the lights that are being backscattered represented by the green lights. So for a given depth in the retina, you completely pass the pinhole and the other going to be blocked optically. Okay? So this is a way to get rid of some part of the multiple scattering light and the autofocus light and increase your signal-to-noise ratio, as you can see here. So you can directly see photoreceptors with a good signal-to-noise ratio. The problem is that you are illuminating with a point which has been scanning the field of view. So it's quite low, low acquisition. And this can also create some distortion. So as the eye is constantly moving and there's some dynamics processing, you can see here that the fact that you are scanning over the field can have some motion artifacts that you can change the structures of the retina itself. So you can see a occurrence of distortion here. So it's sometimes can be hard to see what's the truth of the structures of the retina. And one way to mitigate this problem is to have a small field of view to scan as fast as we can with good sampling to have high resolution. We have different geometry of illumination detection. So we saw the full field, so the flood illumination or the fundus camera. And we also saw the confocal, where illuminate with a point, but we can also think about partial field approach like line scanning with thermoscope and checkboard. So again, it's a question of trade-offs every time. In the last part of my talk, we saw a little bit about the challenge. We mainly focused so far about reflectance map of the retina, but there's also other methods to illuminate and image the retina. And I'm going to go through them very fast just to have a notion what we can do. So I just mentioned that we'd be very happy to get rid of multiple scatter light, but we can also take advantage of this multiple scatter light to have somehow a transmission image that you have a phase contrast. These are two examples that you see here. Using a point scanning confocal, here is not going to be confocal anymore, but it's a point scanning system and a full field system. And for a basic, what's happening is that in a confocal, the difference is that you just add a shift from the confocal to the pinhole. So you shift the illumination pinhole compared to the detection pinhole. And this will allow you to only collect for multiple scatter lights, which will generate different contrast. So this is a way to explore, for example, the red blood cells passing through vessels, as you can see. You can also think about motion contrast. So Michel talked about OCT and geography. Here you can see OCT or geography and how adaptive optics can increase the resolution and details from the capillaries, especially in the foveal avascular zone. We can also do that using phase contrast. So if you look at the standard deviation, we can separate what's moving from what is static in terms of retinal features and see the vessels. And we're also going to have some talks from Michel, but also Léo Puyo from laser Doppler holography. It's another way also to have this type of motion contrast, especially for vessels. There's other contrasts such as autofluorescence, chemical contrast, absorption contrast, motility, organelles motility contrast, etc. So there's a field of finding new contrasts of imaging that's also very exciting. So with all these techniques, what can we finally see in the retina? So we can see that in the red, it's all the features that we could see without adaptive optics, but using adaptive optics help us to see other features that were not possible before. So it's the green bars going until almost 1 micrometer for rods, for receptors, for example. And there's still some space so the black bars are these features that we cannot see yet. We could spend a whole day to talk about this chart, going one by one and see why we cannot see them. Of course, we don't have the time, but there's still some space for new developments to see different features as an engineering point of view, and for a clinician point of view, exploring what we can see, especially with adaptive optics, which is not too much the case in clinics so far. It's being more and more, but there's some room to develop yet still. So I just want to show one of the images that I think is the most beautiful one from Miller's lab from Indiana. It's used adaptive optics and OCT, and they can have access. You can see here a cross-section of the retina and the en face image for each depth that's being scanned by this yellow line. So we can see a lot of things, features, structures in the retina now. So what else should we do? Michel already mentioned, he spoiled me somehow. I think one of the key things is multimodal ophthalmoscopy, because we have different imaging methods that are complementary, give different information. So why not developing a system that can do them in parallel, in order to correlate their informations that will help us to learn more about diseases and even about anatomy of the retina, in vivo retina. And I also want to highlight the ophthalmography or functional imaging because what I've showed is mostly a structure image, but if you, in clinical point of view, if you have a structure change, sometimes it's too late. So why not probe the function and see if there's any degeneration happening before any structure change. So I think this is a very hot topic. We'll have a session with a lot of talks in this topic, and I think it's really something to work in the future. So with that, I hope I was clear, and this talk will help you through the conference. So I'd like to thank you for your attention and enjoy the conference.
Thanks for a really nice talk, Pedro. I think there's a lot of slides I want to steal for talk. Does anyone have any questions for Pedro? Or online?
If you have questions online, I don't know if you heard, do not hesitate. Or later during the coffee.
I'm sure we can find time during the coffee. If anyone wants to take we're maybe 3 minutes ahead of schedule. If anyone wants to run out to grab a coffee or whatever, they're welcome to while Anna charges her presentation.
Il est encore en train de voir parce qu'il est comme ça. J'espère que ça passe.
That's really interesting about this contribution, because it's not really our position, because we're very aware.
Which we know when we treat them, yeah.
Surgery.
I'm sure. And I come tomorrow, so could bring that up. And then I am based in yes, sorry. There's not deep. That just worked out with all the remote ones. Yeah. You know, existing so yeah, anyway, I'll maybe catch up and look at. But I mean, I know the guys who make us quite well, so I'm with that. Okay, we'll catch up soon. Okay, thank you.
Ah, c'est possible que non, en effet, oui. Il doit manquer le... Attends. Je crois, ouais, je crois que je partage pas le bon. Attends. C'est bon là. Ouais.
Okay, so I see most people are back here, so we're going to get started on the third of the 4 talks in this session. So welcome to Anna Verschueren. Thank you for your participation.
So, hello everybody, I'm Anna Verschueren. I'm a former now member of the Paris Eye Imaging and the East of Paris group, so the subgroup of biologists and histologists experts within the Paris Eye Imaging group. And I'm currently working at Université Paris-Cité as a full-time teacher. And today I'm here to give you an introduction of the eye from a biological point of view. So biology for the dummy, basically. My main focus will be to give you the keys to be able to understand, of course, the basic biology, but also like the terms and terminology used in most biology paper applied to the eye that you will need. I will start with a quick introduction of the structure of the eye and especially of the retina, and I will talk to you about the 3 different cell types that you can find within the retina. And then I will focus on each cell types one after the other. And for each cell type, I will give you, I will make links with the presentation that you had with Michel first and talk a bit about pathology and pathology, including and taking those cells into specific focus. So without further ado, the biological point of view of the eye and especially of the retina. So most of you, of course, know the anatomy of the eye and the light path, the following, that the light enters through the cornea, pass through the iris, the lens, and is focused especially, if I can have the laser pointer, on the retina at the back of the eye. A quick reminder and a bit of, I would say, like vocabulary, that way we all know that what we are talking about. I, as a cellular biologist, will often talk about plastic membrane and cytoplasm. Plastic membrane is basically the delimitation of your cell, the lipid membrane that you will have around your cell, and cytoplasm is the main liquid compartment where everything is inside of your cell. And you will also have the extracellular matrix, which is everything that the cell produces that is outside, that is our outside environment. And the main component will be fibrous protein. Most of you have heard about collagen. And depending on where you are within the organism, you will also have a polysaccharides gel type structure. That cytoplasm and plastic membrane can create cytoplasmic extension, and you know some of them, for example, when we talk about dendrites or axons, or when we talk about cytopod, all of them are cytoplasmic extension, like basically the little arms or the little tentacles, depending on how anthropomorphic you are with your cells, of the cells themselves. Within your cytoplasm, you will find what we call organelles. Organelles are smaller lipid membrane components and compartments within the cells. You know of the nucleus, which we'll often see, which will have often optical properties that are different from the rest of the cell because it's so densely packed with DNA. And other organelles, the one that you all know, I'm pretty sure of, is the mitochondria, the powerhouse of the cell. So the organelle that will transform glucose into an energy that the cell can use. But you also have others like the endoplasmic reticulum or the Golgi apparatus, which main function is the protein production within the cells. That basic shape that you can see here with a bit more complexity can really change from one cell to the other when you have a specialization of that cell. To example, here you have your neurons and you have photoreceptors, which you can see are pretty far away from my, I would say, like egg-like cell types that we use most of the time. Just after Pedro's talk, I would imagine that for most of you, the retina is either this, so different layers with different intensity, more or less precise in their definitions, either coming from OCT or adaptive optics, or like this, like a pretty schematic view with a few cells, one close to the others. For me, as an histological biologist, as an expert with histology, I have a lot more definition of the different cells and where they are and where the extension are within that tissue. But of course, the price that I need to pay to have that type of resolution and that type of definition of the different cells component is that I'm working mainly on dead tissue. So the retina. We have three main different cell types within the retina. We have the neurons, we have the support cells, and we have all the cells that are within the blood vasculature and that are the main components of the blood vessel themselves. If we translate the different layers to their cellular component, we have different types of layers, and you will see that each cell is often within different layers of the retina. If the first type of layer that we can see is the nuclear type of layer, you have the ganglion cell layer here, the inner nuclear layer, and the outer nuclear layer. As you can see, they are, if you watch on my histological part of the schematics, you have, of course, a lot of nuclei, and they are mainly the nuclei of the neurons. In the ganglion cell layer, you will find all the nuclei of the ganglion cells. In the inner nuclear layer, you will find the bipolar cells, amacrine cells, and horizontal cells layer. And in the outer nuclear layer, you will find all the nuclei of the photoreceptors. Other cells can be part of those layers, but they are not the main component. And we can also find the retinal pigmentary epithelium, which is juxtaposed to the retina. You will find either the RPE being part of the retina or not part of the retina. Sometimes it's considered as the pigmentary retina. You can find that type of name. Depending on the biologist, the RPE can or cannot be considered part of the retina. Just depend on your definition of the retina. Other layers within the retina contain the plexiform, two plexiform layer. Plexiform here is a way to say that you have a lot of cytoplasmic extension from different type of cells within that layer. In the inner plexiform layer, you will find all the connection between the ganglion cells, the bipolar cells, and the amacrine cells. And in the outer plexiform layers, you will find the synapse of the photoreceptors and the extension of the bipolar cells and the horizontal cells. You also have two other layers, which are only photoreceptors and which are the inner segment and the outer segment of the retina. And finally, you have three other type of layer, and I'm sorry for all those layers, but I really do need to have like the translation from what you see in optical adaptative and cellular different types. You have the membrane. When we are talking here about membrane, we are talking about extracellular membrane. Those are not plasmic membrane. They are outside of the cells, and they are mainly, their main component is collagen, and they are limiting between the different type of tissue. You have the Bruch membrane, the external limiting membrane, and the internal limiting membrane. And I will also talk about the choroid today. Choroid is not as per se part of the retina, but because we want to understand the retina and we want to understand the vasculature and the blood support of the retina, we will need to talk about that main vascular system. So I'll start with talking a bit more about the retina blood vessel. And for that, I will need a bit of biology 101 about those blood vessels. First, what are the main function of blood? The main function of blood are to bring nutrients and to get rid of waste for every cells within your organism, but also to bring some communication, for example, the hormones. And also there is a role in immunity to bring some immune cells toward the tissue and to make them circulate within the organism. You have arteries, capillaries, and veins, and the main difference between the three is that arteries bring the blood to the tissue, capillaries exchange the blood and the component of the blood with the extracellular liquid of the tissue, and veins will take back the blood and, for example, the waste and the CO2 back to the circulation and towards either the pulmonary, the lungs, or the heart. If you check the structure of a blood vessel, most of the time, the simplest structure you can find in a blood vessel is within the capillaries. You will only have one layer of cells, the endothelium, and outside that layer of cells, you will have a membrane, a basal membrane, that the cells themselves secreted. If you go towards much bigger blood vessels, you will have a much more complex structure within which you will find a lot of different cell types. And you will find difference between arteries and veins. For example, the number of muscle cells that you will find inside the walls of the vessel, depending on the function of the vessels, between arteries and veins and between the different parts of the organism. In the retina, we have two main vascular networks, the one that is within the retina and the one that is juxtaposed to the retina, the choroid. The first one, the one that are inside the retina, are structured that way. They have 2 to 4 vascular plexus. Here, a plexus means that there is a layer. They feed mainly the inner retina, and they are composed of continuous capillaries. Continuous capillaries means that within this part of the retina, the transfer of nutrients and the transfer of liquid is highly restricted. And when we are talking about the choroid will feed mostly the outer retina and is composed of fenestrate capillaries. Fenestrate capillaries means that in this part, there is a lot of exchange possible between the inside of the capillaries, the blood, and the outside, here, the outer compartment of the choroid and the RPE. Why was I talking about those type and the exchange that we can find in the capillaries? Because one of the important concepts that you have in the biology of the retina and biology of the vascular network within the eyes is the blood-retinal barrier. The eye is an organ like the brain, for example, and some other organs within the organism that has an immunity privilege that is especially separated from the main bloodstream. You will have mechanisms that are protection from the main immunity system from the organism. The immune cells won't, in a normal or in a physiological situation, be able to go from within the blood to the tissue itself. This barrier is, I told you, for the vascular network, the fact that the capillaries in that part are pretty much, I would not say waterproof, but there are a lot of tight junction and there are very few exchange. And in the external blood retinal barrier, I told you that those capillaries were giving a lot of exchange, but the barrier is a bit different. Here, the barrier will be found between RPE cells, which will create that barrier between the exchange of the blood and the retina itself. So we'll protect the retina from what could be inside the blood. So a pathology focus where we have a lot of damage and that the damage are coming from the blood vessels is the diabetic retinopathy. You've heard a bit about it from Michel, of course. You have those observations we've already seen with Michel when we are talking about diabetic retinopathy, the symptoms that we can see, or depending on the stage of the diabetic retinopathy, or microaneurysm, so a small capillary that will enlarge abnormally at some point. Abnormal neovascularization, so you will have creation of new blood vessels in some part of the retina that weren't there before, or sometimes retinal edema, which are abnormal fluids accumulation within the retina, which explain that at this point, somewhere, the hematoretinal barrier had been broken or is not as strong as it should be. I will give you a few physiological hypotheses about how it's working. We are not sure about exactly how it's working. This is the main hypothesis and the one that we are working to understand and to know if it's true, but this is how we suppose that it's working. The diabetes main problem is that there is a really high glucose and that there is a really high glucose within the blood because the glucose level is not as stable as it should be. And one of the problems is with the high concentration of glucose is that it pretty soon became toxic for the cells. And the first cells that are in contact with this high amount of glucose are the vascular cells and the cells from the vascular vessels walls specifically. So pretty soon, a very high concentration of glucose will alter the vascular permeability. You will have loss of cells from the walls. You will have microaneurysms, so deformation of those capillaries, and sometimes you will have an occluded and degenerated capillaries. So you will have problems within the choroid and within the retinal vasculature. And those will in turn bring other problems because there will be a lot of inflammation and because the permeability will bring new immune cells that should not be able to pass from the blood toward the retina, but that now will be able to pass. And also because there are some occluded capillaries, you will have low oxygen from some parts, and low oxygen is unfortunately in the organism a signal to create new blood vessels. So here, this is the main hypothesis for the blood vessel proliferation, the neo-formation of vascular network that we observe sometimes in the different type of diabetic retinopathy. Now that I talk about all the blood vascular cells, I will go to the support cells within the retina. What I call support cells is a subtype of cells where you will find main roles in either immune system, architecture of the retina, or homeostasis. Homeostasis as in the maintaining the concentration and composition of the outside liquid, of the outside extracellular matrix of the cell, which is absolutely crucial for their function. And before talking a bit about support cells, I will talk to you a bit about inflammation. You have here a huge schematic that I will absolutely not detail, but it's just for you to have an image of the fact that inflammation is a very highly complex mechanism within the body. And most of the time, how it works is the following. You will have a detection of an abnormal component, for example, a component that is supposedly inside the cell that can be found outside the cell because some cells are broken. This detection will recruit immune cells, both resident and from the blood circulation. You will have some activation of molecular cascades that will all go to a swelling of the area, so more liquid within this area. And finally, with the immune cells and the cascade, molecular cascade, you will have a repair involving tissue scarring. Within the retina, there is a huge hematoretinal blood barrier that will stop most immune cells from going from the bloodstream toward the tissue. But there are other immunosuppressant strategy in place, which the main function that we currently think they have is to avoid scarring and swelling of the retina, because scarring and swelling of the retina, of course, bring problem to the optical properties of the retina. So this is the main function that we think is to the immune privilege of the bone. So those support cells, you have 4 different types. You have the astrocytes that are specifically working with the ganglion cells. You have the Mueller cells, which have, as you can see, they are absolutely huge and they surround most of the other cells of the retina. So they have a huge architectural support role within the retina. We have the microglia. Microglia are the residing immune cells in the retina. They can migrate and they can transform themselves into macrophage if there are inflammation within the retina. So the retina has its own immune system and its own immune residing cells. And finally, you have the RPE, which is highly pigmented, which allows it to stop the scattering of the light. So it has a very optical important role. And other functions are specifically the recycling of the component from the photosensitive cascade for the photoreceptors, meaning that the RPE are crucial to maintain in the long term the role of the photoreceptors. Pathologic focus that is on the support cells is the age-related macular degeneration. I will just give you back a few of the observations Michel brought a few minutes ago. You will see when we are watching an AMD, we will first see some drusen, so some waste accumulation in between the Bruch membrane and the RPE. And when we are in the later form, we will have either a dry or wet form. And for example, for the dry form, we will have a degeneration of both the RPE and the photoreceptors in the central retina. I will specifically focus here on the dry form. The hypothesis that we have about how the pathophysiology of this disease works is that drusen or RPE cells that are overwhelmed, and so that will accumulate some debris, some wastes in small pockets outside of themselves, and that these degeneration and malfunction of the RPE cells will in turn provoke a disruption of the photoreceptors metabolism. As I told you, photoreceptors are highly dependent of the RPE cells and the RPE function, and that will lead to their degeneration in a second. And finally, we have what are often the stars of the retina, which are the neurons. So what is a neuron? One definition of a neuron is that it's an electrically excitable cells that can communicate with other cells via specialized connection called synapses. It will emit an electrical signal called an action potential. And you can see here, you will have dendrites, which are cytoplasmic extension that are contacting other neurons, and axon, where most of the transmission of the information takes place, and then a synapse, where that neuron can transfer its information to other cells, most of the time other neurons. In the retina, we have a very complex network, even if it's often less complex than the one that you can find in the brain. But we often separate it to understand it it's a bit artificial, but into different network, a vertical pathway and a lateral pathway. The vertical pathway is composed of the photoreceptors, the bipolar cells, and the ganglion cells. And in the lateral pathway, we include horizontal cells and amacrine cells. Today, I will mostly talk about the vertical pathway because it's becoming very, very complex if you just include amacrine and horizontal cells, and we don't have the time to do everything today. So the vertical pathway is functioning as follow. First, you have the light that will be detected at the photoreceptors level, and especially at the outer segment level. And the photon absorption is translated by the cell into an electrical signal and especially a depolarization of the membrane of the cell, of the plasmic membrane of the cell. Here you can see that we consider this to be a type of analog signal, meaning that the higher the intensity of photon received by the cell, the higher the signal and the depolarization of the cell. Then this signal by the photoreceptors is transferred through synapses to the bipolar cells, and we will have two types of bipolar cells, on bipolar cells and off bipolar cells. One being excited by the sensing of light by photoreceptors, and the other being inhibited by the sensing of the light by photoreceptors. This allows for the retina to have two different signals, one signal for light and one signal for obscurity, and there is no non-signal. There is not one of the two options that would be an absence of signal. This is the main function of the bipolar cells. And when we go toward the ganglion cell here, you can see that there is a type of a translation, because the signal that was up to there kind of analog becomes here kind of digital. So we will have a translation into action potential and a frequency in action potential. The more intense your light, the more frequent your action potential, or if you're an off ganglion cell, the less frequent your action potential. And action potential are very important because they are the language of the brain. That is the only type of language that the brain will understand. And those ganglion cells will then, with their axon that is going up through the optic nerves and toward the visual pathway within the central nervous system, give those signals to the brain. There are other levels of information integration, because here I just give you the very basic level of information, either light or either no light, but there are also a lot of integration about light contrast, color contrast, and also movement detection that are occurring within the retina itself. And the shape and property of the lateral pathway can differ with where you are within the retina. The peripheral retina doesn't integrate the information exactly the same way at the central retina. Pathology focus on photoreceptors is pigmentary retinopathy, where you can observe first as symptoms a loss of night vision and a loss of peripheral vision. And if we look at an eye fungus, we will have an abnormal pigmentation of the eye fungus. The physiopathology hypothesis current, you will find different hypotheses. This one is just one that is understandable, and that is one of the main one, is that there will be first a photoreceptors degeneration of the rods, explaining why we lost the night vision first, then of the peripheral cones, explaining why it's followed by a loss of peripheral vision. Then, because the photoreceptors degenerate and the RPE is interdependent with the photoreceptors, there is an overwhelm of the RPE cells, which will in turn degenerate themselves. And this leads to an hematoretinal barrier disruption. Then this disruption will lead to inflammation and abnormal cell components, for example, macrophage recruiting. And this in turn will give more tissue damage within the retina. So in conclusion, you know now that there are a lot of different cell types, but there are three main different cell types within the retina. The architecture is pretty complex, where different layers will contain different types of cells. The proportion and the organization of those cell types will vary with the eccentricity of the retina. Here I choose a spheric portion of the retina where everyone is present, but you can have different composition along the periphery. And finally, I want to give you that message is that all those cell types are independent, and most of the time when you have a problem within one cell type, you will soon have problems within the other adjacent cell types. So I would like to thank everyone, to thank, of course, the Paris Eye Imaging and the organizer of today's conference to have asked me again to do the Biology 101 talk. And don't hesitate to reach out. I may not be part of the team anymore, but of course I will answer any question, and I'm super happy to be here today. So please send me an email if you have any basic biological question. I don't care. Thank you very much.
Thank you, Anna, for this really nice, clear talk. Does anyone have a quick question? We maybe have time for one. Or online? Okay, if not, then I guess we can talk during the break, and we'll go on to the last talk of the session. Olivier Thouvenin is going to talk about microscopies.
Hello, good morning, everyone. My name is Olivier Thouvenin. I'm assistant professor in optics at the SPCI Paris and a group leader at Institut Langevin here on label-free microscopy techniques. And today I've been kindly assigned by Kate to give this introductory course on microscopy. And well, I have to admit it's a bit difficult due to the broad audience that there is today, but I'll try my best to give you good insights for most of you. So the main idea here is you've seen with Pedro's talk this morning that they can build very complex systems in order to fight against when you want to do high resolution in vivo imaging of the eye. You need to build complex system to go from this low contrast image, blurry image, into a very nice image like this, where you can see all the photoreceptors. And my goal is a bit different, is to build systems that are much simpler and with even more resolution. And one solution to do this is to get rid of the eye, as Pedro mentioned earlier. It's mostly because the eye is a terrible optical systems that you have to fight against all these problems. So with simple systems like this that I will be describing in the rest of the talk, you can achieve images like this. It's still photoreceptor. Well, it's imaging a photoreceptor layer in the retina, but this time in an explant. And here's the small dots that you see are the rod photoreceptor, as compared as before, where you only see cone photoreceptors. So you can appreciate the 4 to 5 times increase in optical resolution. And so far, optical microscopy has mostly focused on explants and has been applied to histology and has been useful for fundamental biology to understand the biology of the structure and the function of the retina, and mostly in animal models. But quite recently, there was a new technology called retinal organoids that's enabled to bridge the gap between to get this optical resolution, to get this optical microscopy closer to the clinics. And the idea is of these retinal organoids. So it's going to be the topic of Olivier Gourou's talk this afternoon, but I'll just briefly describe it here. And the idea is you can take cells from a patient, and using the right cocktail of molecules, you can turn these cells into any type of tissue that you want, and especially in retinal samples. So from the same patient, you can have hundreds of retina that you can access for months and 24 hours 7. And you can guess that it's complicated to have with a patient. And the nice thing about it is now with this retinal organoids, you can have structure that are a bit different, but still similar to the retinal structure organization. And it was really the main interest of bringing this new day in this conference. Thanks to the development of this retinal organoids, is how can we do optical microscopy in order to understand and to apply something on patient-derived cells. And it was the idea of this day to talk more about biological aspects of these samples and on optical microscopy. So today I will first describe the main characteristic of a microscope, and then I will talk about fluorescence imaging and label-free imaging although I will only have the time to explain you how to transform an essentially OCT into a microscopy technique. So let's start from the basic with the microscope objective. And again, the main difference from in vivo imaging is instead of using the eye to focus the light into the retina, you can use this nice microscope objective. But there is a lot of complexity, but it's hidden inside this microscope. Still, so there are a few numbers that are used to characterize. And the first one is the one that people always thought about, and they only give this number to describe the microscope, was the least useful number, actually. And so it's a magnification. Usually when you ask people, what resolution are you using? They say, I'm using a 60x objective. And please, after this talk, do not do that anymore. Because this number just controls the magnification and it's not even a complete information. So the second number is more important, and I will go back on it later. It's the numerical aperture allowed by this objective. And this number controls the resolution. And there is this third number, which is often not even written on the objective, which it's called the tube length focal length. I will come back to it in the next slide. But this number is important for calculating the magnification of the objective. So this is a very basic microscope, but quite standard. So you have a light source, you illuminate your sample, and you make the image of a sample onto a 2D detector. And for this, you use a pair of lenses, so one objective and a tube lens that enable you to make the image of the object onto the camera. And if you do optics, you know that the magnification is just a ratio of the focal length of the tube lens versus the object. And magnification is just you can make the image of the object bigger and bigger on the camera. And by doing so, you also reduce the field of view, but also I'll be coming back to this later. But actually, the important point is the magnification is really the ratio of these two focal lengths. So even with a 60x objective, again, you have the liberty to choose another tube lens so that you can transform your system into a 100x magnification system, or even 20x, or you can choose any type of magnification, even with a 60x objective. And of course, you can complexify the system, but most of the system uses this pair of lenses strategies. But yet, magnification is not enough. As you will increase even more your resolution, you'll start to have images that are blurred like this. And this is not due to some electronic part, it's due to the diffraction limits controlled by wave physics. So you can show that if you send a parallel beam on an objective, you can only focus the light onto a spot which is not infinitely small, but which has a lateral and axial expansion. And as Pedro mentioned this morning, you have this lateral extension, which depends on the wavelength divided by the numerical aperture. Again, I will come back on this. And an important point also is that the axial resolution is different, and it depends on the inverse of the numerical aperture squared. And this is going to be at the core of many problems that arise in microscopy. So the numerical aperture is simply the angular distribution that the objective can collect, or that can come out of the objective. And the more angles you can put, the smaller the diffraction limit spots becomes, and the more resolution you start to have. So if you can collect more angles like this, you can start resolving some small plots. And essentially, if you want to increase the angles that can enter the microscope, you can either increase the diameter of the objective, or you can also change the focal length of the objective. And the smaller the focal length, the more the wider angles you can reach. And for small angles, and this is important to keep in mind, for small angles, essentially the numerical aperture is the ratio between the radius of the objective divided by the focal length. So in conclusion, what controls the resolution? Actually, both notions, both the magnification and the resolution. So if we start a bit in the opposite way around, if we start with a well-designed systems, and how can we degrade the image? So you have two solutions. Either you can decrease you can decrease the magnification so that the pixel size become bigger. And actually, what it does, a pixel, it averages the intensity over the area of the pixels. So if you increase the size of the pixel, you will do spatial averaging, and then you will lose the nicely contrasted cells that you have before. The other option, of course, is to limit the resolution by a factor 2. And here again, you lose what we call resolution. But in short, the resolution is the most constraining value between this pixel size, which is just a special sampling effect, and the resolution. So let's mention the field of view that you can image. As we mentioned earlier on the magnification, the total field of view, it usually depends on the sensor size, so the camera size, and the magnification. So let's say that you have a typical CMOS camera with 1,000 pixels in each direction, and a typical pixel size of 6 microns. So if your magnification is 100, then you have a small field of view, 60 by 60 micron, but then your pixel size is 60 nanometer, so you are sure that you will be diffraction limited. There is no sampling problems. Instead, if you use a low magnification of 1, you have a large field of view, so you're happy, but then your resolution is decreased to 12 micron, which is about 2 pixels, and here the pixel size, the final pixel size will be 6 microns. So if you want to do large field imaging, there are a few solutions. You can increase the number of pixels, you can decrease the pixel size so that you can use lower magnifications. But all this come at a price. And actually, it's much more dramatic when you think about the actual resolution of the systems. So we've discussed of these 4 equations. So essentially, if you want a large field of view, what you want is to have a low magnification. And a low magnification is to have a larger focal length of the objective, which means a small NA. And if you have a small NA, then your transverse resolution decreases, but also because of this dependency on the axial resolution of the square, on the square of the numerical aperture here, it makes it much more dramatic in the axial direction. So again, let's give some numbers with a numerical aperture of 0.1, which is about the one in the eye. If the pupil is normally dilated. What you have is a transverse resolution of about 5 micron, which is okay. It's about the cell resolution. It's not perfect, but it's okay. But the axial resolution, again, because of this dependency on the inverse of the numerical aperture squared, it becomes very large, on the order of 100 micron. In this case, it's about the retinal thickness. And again, this is at the core of one problem, that's when you want to achieve large field imaging, you are limited mostly by the axial resolution of the system, which is why, and it's going to be something that I will be describing later in the talk, techniques such as light sheets or OCT have become very popular in a very fast period of times, because they found ways to decouple the axial resolution from these geometrical problems. So now we can talk a bit on the penetration depths that you can reach in optical microscopy. And actually, it does not depend so much about absorption, because if you work in this white region, which is called the therapeutic window, around, so from 0.6 micron to 1.5, there are little structure in biological samples that absorb light, and you can estimate the typical length after which half of the energy is absorbed, and it's about 1 centimeter. And actually, it explains this kind of image where you have a light on the other hand of the hand. And what you can see is the light can come out of the end, so there is no absorption, but still you lose all the structure of the illumination and you lose all the structure of the light. But it's not due to absorption, it's due to scattering. And scattering is the ability, was an interaction between light and matter that changed the orientation of the light with this night formula for small objects. And it's again at the core of the most, well, this is what limits the penetration depths down to from what's depending on the wavelength from 10 micron to 1 millimeter. And essentially from this formula, it's not accurate in all conditions, but this important parameter is this, so it's the dependency on the inverse of the wavelength at the power 4, which explains that if you go toward the red and deeper in the infrared, you can penetrate longer in tissues. And so this is the power law that you have in log scale. And after some point in the infrared, you start having absorption and being limited in the millimeter range. But here, the main limit, again, is scattering. And this is also what explains why techniques such as 2-photon or 3-photon microscopy, because they are using photons deeper in the infrared, they can penetrate deeper inside samples. This scattering is a small formula can also explain the usefulness of what we call the clearing agents that people use in fluorescence microscopy. So the idea is you want to turn this kind of sample, of opaque sample, into transparent one. And again, because the problem is not absorption, but scattering, and that the scattering typically depends on the difference in optical index between the medium and inside the cells. The only thing that you need to find, and it's not easy, I admit, but the only thing that you need to find is to do index matching, which is to find a medium which has exactly the same refractive index as inside the cells. And obviously, there are many heterogeneities in the refractive index inside tissues. So if you want to make some sample fully transparent, you need to find a way to fixate the sample and to make the medium enter inside the cells and remove the lipids, for example, which makes things complicated. But then you can make these tissues completely transparent to optical waves. So let's forget about this number, and Pedro mentioned them, but what happens now if you want to image a sample? Still, you have your a thick sample. So you have your illumination, you send photon onto the sample, and you want to image the photons that come back to your detector. So they are, and actually you are interested in one specific layer inside this tissue typically. But if you do this, what you collect into the camera is this big blur of this massive flux of photons that come from all the depths of the sample. And typically, just to give you a short order of magnitude, there are about 1 million or 1 billion times less photons from one plane of interest compared to all this flux of photons that come from all the depths and from the surface of the sample. So all that to say that in optical microscopy, the main problem and the main thing that you have to fight against is a contrast problem. There are many photons that come back to the camera, but the idea is how do you get information out of this and how do you filter the photon in smart ways so that you can image at structures of interest. And there are a few solutions that I will go through in the rest of the presentation, either by using fluorophores or by using a temporal filter in label-free imaging. So one way to solve this contrast problem that you have is to use fluorescent proteins or fluorescent fluorophores, which are molecules that have the nice property to have absorption, that absorb the light at one wavelength, and to have this non-radiative processes, which decreases the energy so that the light can be re-emitted at another wavelength with smaller energy, meaning more in the infrared. So essentially, these molecules, they absorb the light at one wavelength and they re-emit at a second wavelength, which make it very easy to discriminate the photons that come from a structure of interest compared again to this massive flux of photons that would come back to your camera. And then by combining the fluorophore that you have, you can make very nice images because essentially you work on a dark background. So the structure of such a fluorescence microscope is the following. So it's very similar to the image that I've shown before. The only difference is you need to use a precise set of filters here so that you can, so let's say you have a fluorophore that you can excite in the blue region and that will emit photon in the green. So you need to find the perfect set of filters that will filter all the blue photons. So that's only the one that have crossed the structure of interest can be detected in the camera. And again, it's not trivial because again, there is this 1 billion factor between the number of photons that would come back to your camera and the number of photons that come from the structure of interest. So you need to find very efficient filters and to combine possibly many filters to see only the fluorescent photons. There are different classes of fluorophores. The first one is organic or synthetic dyes, such as these quantum dots, that have the advantage of being very bright and stable. But because they are synthetic, you need to inject them either inside the cell in histology, by copying with antibodies, or by injecting them in the circulation, such as this fluorescein angiography in the retina that you may know. But fluorescence microscopy was particularly useful, especially for live imaging, with the discovery of fluorescence protein. And because these are proteins, you can extract the gene that code for this protein, and you can insert this gene in any sequence, in any DNA sequence of interest. And you can couple the protein to virtually any molecule that you want. So that you can have a very strong molecular specificity of this protein. And eventually you can even use some nice properties, some nice genetic properties, so that you can do this beautiful multicolor scale type of image. The problem of this protein is, so because it's genetic, they can be translated in live samples, but they are fragile, and you can only use them in model systems where you know the genome. So it's typically complicated to do in humans, except from these organoids things that we'll discuss this afternoon. There is also a last thing about fluorophore that I want to tell here. Sorry about this. This unfinished slide. But it's what I call the functional reporters. So essentially, it's fluorophore that modulate that fluorescence intensity based on the chemical activity inside the cells. And one of the most famous ones is this calcium sensor, which increases their fluorescence when there is calcium entering the cell. And essentially, which is when the neuron is active, there is a massive burst of fluorescence that you can use to track the neuronal activity. This is something, and there are many other fluorophores that you can use to probe virtually, again, many chemicals, such as the ATP, the pH, or many other things. And this is also something that you can do post-mortem for in histopathology with a nice a molecular cascade called the CFOS cascade, which enables to translate the fluorophore only if there is calcium that has entered the cell. So it's actually work as an integrator of activity throughout the life of the animal, which you can use again. So even after the animal is dead, you have a measurement given the concentration of fluorophores. You have a way to measure the total activity that this neuron had during its life. But the problem with this probe is so they are designed so that they can bind to calcium or any other molecule. So they act as buffers, and they can impact quite strongly the physiology of the cells. So if we go back to imaging, we still have a problem. Which, so I've told you that in fluorescence, it's easier because you change the wavelengths and there are less photons that come into your detector. But if the fluorophores are everywhere inside the sample, still you will excite all the fluorophore inside the samples, and there will fluorescent photons that will come from all the depths of the sample. So essentially what you will get is, again, this blood image with low contrast. So what you need to find is it's a property called optical sectioning, which is the ability to collect photon only from one given depth inside the sample. And for this, so Pedro has presented earlier already the confocal configuration, which is a point scanning technique, where you just have one point. If you excite fluorophore from plane outside the focal plane, they will be rejected by confocal pinhole conjugated with the plane of interest. And with this, you can increase the signal-to-noise ratio of your images. But as Pedro said, in the retina, it's a quite slow process because you have to scan over a wide field of view. So there are some strategies to go faster, as the spinning disk approach, where you just multiplex the number of points that you have onto camera, and by spinning the wheel of you make multiple points in confocal, and you can increase the speed and do video rates imaging of fluorescence activity. Then to finish with, I will just talk shortly about light sheet microscopy, because again, the goal was to do was to optimize the field of view that you can image. And what we've said earlier is, if you want to have a large field of view, then a low magnification, and then the axial resolution becomes very poor. And in confocal, the best axial resolution that you can have with the confocal pinhole is the depth of field of the microscope, which is the typical axial resolution. In light sheet microscopy, what you do is you eliminate the sample from the sides with a light sheet, which is a plane of light which is transferred to the imaging. And thanks to this configuration, you can completely decouple the thickness of this light sheet to the geometrical parameters of detection. And then you can tune the axial resolution by choosing the parameter of these excitation objectives. And then there will be only the fluorophore at the plane where the light sheet goes. So that will be detected, and then you can reach high axial resolution, even with low magnification. And then you can do centimeter scale imaging, fluorescence imaging, under the condition that you have this optical clear, this clearing approaches that I've mentioned earlier. So in label-free imaging, in OCT technique, you need to find other strategies, because you cannot, well, if you want to do label-free imaging, you cannot, you don't have these fluorescence properties to change the wavelengths. But I will show you that we are using another interesting property of interferences. So the idea here is, again, you send some light onto a sample, and what you want to do is to select the photons that come from only one depth inside the sample. And you want to filter out all the photons that were either reflected as a surface or backscattered from different depths. And you can think of solutions as the ultrasound scanner, where you will use the time information. So how much time the photons have propagated before reaching the detector. And obviously the one that were reflected at the surface would have propagated for less time. So essentially what we want to do is to find a way to time the light and to time the trajectory of the photon inside the medium. But if you give some number, again, because of the high speed of light, it would require a very fast detector, which does not exist on the market. So we need to find another solution, which is essentially to use interferences. So it can be seen in this way. So let's say that you send a very short pulse of light. So what will happen on the light that arrives onto a sample is this blue curve, meaning photons that are backscattered at all the different depths inside the sample. And here, what you want to do in interferometry is to correlate this with the second arm. So you divide the light beam in two parts. And the second part goes onto a reference arm in which there is only one mirror. So that's the pulse of light, which would only have one single propagation time. And the interaction between the two beams only happen in at a given location, which will define the depth at which you are looking at. And obviously, it's complicated to have these pulses of light. So we're using in interferometry the property in this type of systems, the intensity that you collect on a camera is the sum of the two intensity of the two arms plus an additional term called the interference term. That's if you're using many different wavelengths, it's localized, meaning that the only photons that can interfere are the ones that have propagated for the same distance for the same time in the sample arm and in the reference arm. So that's, again, you can do time gating in order to select only one given depth inside samples. So the most used OCT technique in the eye is scanning OCT in spectral domain essentially to increase the SNR. But in this case, what you have is you image one depth. So you do an A scan, you're probing the scattering over one depth of the sample. And then there is an optical scanner here that you can scan to get this 2D, these p-scans. And eventually you can scan in 2 dimensions to get volumes. But the drawback of this configuration is if you want to image the entire retina, or if you want to image a large thickness of sample, you need to have the entire sample or volume that you want to probe within the depth of field of your image, which means that in this configuration, you typically want to work at low magnification and then a large depth of field so that you can image your entire sample. But because you have a low magnification, that the transverse resolution is quite decreased. So obviously in OCT, what I didn't tell is the axial resolution only depends on the interference properties and on the spectrum of the light. So the axial resolution only depends on the spectral width of the source, but the transverse resolution becomes limited because you only want to image, you want to image a large depth of field, which typically people think about OCT as a low resolution systems, but actually it's not necessary. So if you have exactly the same systems, but instead of imaging the eye or with a low numerical aperture objective, you can use I&A objective in a way that is completely similar. And you can make images like this at micron scale resolution. And the only constraint is the total depth that you can probe is very small. So it's called optical coherence microscopy. If you don't want to sacrifice completely this depth of field, you can use some strategies such as adding, for example, spherical aberration, or to use Bessel beams to preserve or to decouple the lateral resolution from the depth of field. And again, with this, you can have a large field of view and large volumes, and keeping this 1 micron resolution, for example, in a brain sample. And here at the Institut Langevin, we are specialized in another configuration of OCT called full field optical coherence tomography, in which we're using 2 microscope objectives here to make, well, again, if you remove this reference arm, it's exactly as the basic microscope that I've presented before. So the only thing is we're looking at interferences by adding this second reference arm. And the interest of this configuration is because you make the image of 1 plane at a time onto a camera. And then because you image just 1 plane, you don't really care about the depth of field of your system, because in any case, you will scan the sample to get the entire volume, the entire depth. So that you can use I&A objective, and I have high resolution systems. So this is an example of a zebrafish RB that you can scan by changing the focus of the sample objective and by moving the reference arm to keep the interference. And with this, you can have high resolution images with no compromise between the depth of field that you can reach and the size of the sample. And for example, there was a startup company created by Claude Bocara, who was able to do this high resolution imaging with 1 micron resolution in all directions, with a speed of 1 centimeter squared per minute. And then just to finish with, we can design other ways to filter the photon to add more specificity to this level of imaging. And just to illustrate it, so the idea is, so far we were looking at the number of photons that were backscattered at given depths inside the sample. But now we will instead look at how does this number fluctuate at each depth. And by looking at this fluctuation of photons, we have ways to extract the signal that only correspond to movements that correspond to active transports mediated by the cells, and mediated by cell activity. And with this, we could demonstrate that we can have a very different contrast, enabling to reveal the cells and to measure the properties of the cells. And with this, we could have high resolution image, and typically from organoid, and it's going to be the talk of Stuart Montfort this afternoon, in which we can see the cells and we can see many different molecular processes by investigating, again, the fluctuation of the interference signal over time. And just as a conclusion, if we compare fluorescence and light field imaging, they are actually quite different and quite complementary. So what I've told you is that with fluorescence imaging, you have this molecular specificity that is really important for fundamental biological applications. And for example, you can investigate the effect of some molecules in some process. One of the problems is that all the rest is black. So you lose the context information. So in fluorescence, if you want to increase the information, you increase the complexity by adding more and more fluorophores. If you want to have the context. In label-free imaging, it's a bit the other way around, where in theory you can detect all the structure inside the sample at a given depth. But then it's sometimes hard to interpret and hard to have the specificity. But here you have the context information that you can easily combine with fluorescence imaging in order to have the best of two worlds. That I'd like to thank you for your attention, to thank the organizer of the conference, to thank Kate, Gilles, and Pedro for some of the slides of these applications. And I also want to apologize for all the techniques that I did, especially in label for imaging, that I didn't have the time to present. And that will be, or to start presenting or introducing, and that will be presenting during this nice seminar.
Thank you, Olivier. It was a really nice talk. Is there any questions? We will, unless there's any questions on the Zoom, we don't see. And maybe we will take our break.